Upon completion of this module, you should be able to explain non-pharmacological and pharmacological preventive strategies for invasive fungal infections, and to list different antifungal agents and their uses. At last, you should be able to apply targeted therapy for invasive candidiasis, invasive aspergillosis, and mucormycosis. Here, we will have a quick introduction about the prevention of invasive fungal infections, including the non-pharmacological and pharmacological preventive strategies. Moreover, we will discuss the management strategies and antifungal agents while focusing on the management of invasive candidiasis, aspergillosis, and mucormycosis. Current strategies in the prevention and management of invasive fungal infections are characterized by a lack of reliable diagnostic tests and by the heterogeneity of patient populations at risk. Additionally, a variety of risk factors predispose to different fungal pathogens. The major diseases are invasive candidiasis, invasive aspergillosis, and mucormycosis. Complex prevention and management strategies have been developed, and it is recommended to follow institutional pathways to standardize diagnostic and therapeutic strategies, especially in high-risk populations. Now, we will talk about non-pharmacological prevention strategies for major invasive fungal infections. Firstly, intravascular catheter-related bloodstream infections, which occur when microorganisms attach to the central venous catheter and shed into the bloodstream, leading to candidemia. To prevent these infections, it is important to educate and train healthcare workers who insert and maintain catheters. Also, you should encourage the use of maximal sterile barrier precautions during central venous catheter insertion. Also, the use of chlorhexidine for skin antisepsis, and avoiding routine replacement of central venous catheters. Moreover, it is imperative to ensure the prompt removal of unnecessary lines. Finally, it is valuable to use the antibiotic or antiseptic impregnated central venous catheters if there are high rates of infection. The following figure shows the appropriate steps to be taken to lower the risk of catheter-related bloodstream infections. Secondly, the prevention of Candida auris, which is unlike other Candida species. Candida auris can spread rapidly in HCFs, and patients can remain colonized even after a year, leading to outbreaks. When Candida auris is suspected or confirmed, the patient should be placed in a single room under contact precautions with reinforcement of hand hygiene practices. Additional infection prevention and control measures include daily and terminal cleaning and disinfection of patient care areas using an Environmental Protection Agency registered hospital-grade disinfectant, contact tracing and testing, and prospective laboratory surveillance. Next, we will discuss the prevention of aspergillosis and mold infections. Aspergillosis is primarily acquired by inhalation of fungal spores. Hence, the primary infection control strategy is to minimize exposure to airborne environmental fungal spores within the healthcare facilities during the high-risk period through two steps. The first one is patient education to minimize exposure to fungal spores, and chemoprophylaxis with antifungal agents may be necessary. The second is engineering infection controls or the provision of a protected environment for these patients. A protected environment is a specialized patient care environment for patients to minimize exposure to airborne environmental aspergillus and other fungal spores in acute care hospitals. Additional infection control measures for patients housed in a protected environment include: first, daily monitoring and maintenance of positive pressure in protected environmental areas. Second, minimizing exposures to activities that can cause aerosolization of fungal spores, such as vacuuming. Also, minimizing the length of time that the patients are outside the protected environment for procedures. Finally, provision of high-efficiency respiratory protection when outside the protected environment, such as the use of N95 respirators. Now, it's time to discuss the pharmacological prevention of invasive fungal infections, also known as antifungal prophylaxis, which is defined as the administration of antifungal agents to high-risk patients without signs or symptoms of infection to prevent the development of invasive fungal infections. Different possible strategies based on the diagnosis stage have been described as prophylactic, empiric, preemptive, and targeted antifungal therapy as shown in the following figure. Prophylactic treatment refers to the preventive administration of an antifungal agent to patients at risk of invasive fungal infections without attributable signs and symptoms. Empiric treatment is defined as the initiation of antifungal treatment in patients at high risk of invasive fungal infections and established clinical signs and symptoms, but without microbiological documentation, whereas preemptive therapy is applied when the decision of treatment is based on the early diagnostic test. Finally, targeted therapy needs pathogen identification to be defined. The following table summarizes the chemoprophylaxis recommendations for different high-risk populations for invasive fungal infections. The following table summarizes the major antifungal agents for the prevention and management of invasive fungal infections. As we can see, polyenes amphotericin B is active against most Candida species, Cryptococcus neoformans, Mucorales, Aspergillus species, and resistant to Candida lusitaniae, Candida guillemondii, Aspergillus terreus. The second agent is the azole group, which is a valuable and widely used one. They can be classified into 4 drugs. The first one is fluconazole. It is active against most Candida species except Candida glabrata and Candida krusei. It has proven efficacy for invasive candidiasis in the intensive care unit. It can be taken both intravenous and oral. Finally, it has a good safety profile and a low cost. Secondly, isavuconazole has good activity against most Candida and Aspergillus species. Thirdly, itraconazole has good activity against most Aspergillus species, but not invasive candidiasis. No intravenous formulation is available. Fourthly, posaconazole, which is primarily used for invasive Candida and Aspergillus prophylaxis high-risk patients. Fifthly, voriconazole, which is the first-line therapy for Aspergillus infections and step-down oral therapy for fluconazole-resistant Candida infections. Finally, the last drug class is echinocandins, including inidulafungin, caspofungin, and micafungin. They are the first-line therapy for invasive candidiasis. Now, let's discuss the strategies for the management of major invasive fungal infections. On diagnosis of invasive candidiasis, it is recommended to immediately initiate targeted therapy with echinocandins. Delayed therapy would lead to increased mortality rates so profoundly that mortality has been expressed per hour. Species identification and susceptibility testing are essential to guide management. The initial echinocandin treatment should be replaced with fluconazole if Candida parasilosis is identified. The duration of treatment is at least 14 days after the last positive blood culture. After 10 days of intravenous treatment, stepping down to oral fluconazole may be feasible. Of course, the patient needs to be stable and able to swallow medication, and the species must be susceptible to the oral triazole, usually fluconazole. Finally, we will go through the management of invasive aspergillosis and mucormycosis with targeted therapy. Voriconazole is considered the drug of choice for invasive aspergillosis. In breakthrough aspergillosis during azole prophylaxis, liposomal amphotericin B will be the drug of choice. Moreover, isavuconazole may be used as an alternative therapy for invasive aspergillosis and a new treatment option for mucormycosis. Invasive fungal infections, including candidemia and invasive aspergillosis, can result in significant morbidity and mortality in critically ill and severely immunocompromised patients. Implementation of recommended infection control strategies can prevent catheter-related candidemia and minimize exposure of severely immunocompromised patients to airborne aspergillus spores within the hospital environment. In select patient populations at high risk for invasive fungal infections, antifungal prophylaxis should be considered during periods of intense immunosuppression. Echinocandins are the initial treatment for invasive candidiasis, while voriconazole is considered the drug of choice for invasive aspergillosis.